Good afternoon. Thank you very much for having invited me. I feel very honored because you will very soon see that my main activity is not research and not academic research, but I'm on the field, and I think our missions are complementary, so I hope you'll find a little interest in what I can expose to you about my day-to-day life in this hospital. So I work in a pediatrics ward in the biggest hospital for children in Paris, in the east of Paris, and I have a recent new activity. I'm head of the Child Prevention and Protection Unit of this hospital since a year and a half. So it's quite new, but I would love to have a discussion with you later because we're probably many projects to hold side by side with research. So I have to censor myself because I could talk for hours, but I'll just go straight to the point. What do we deal with when we're in a hospital setting? Colleagues often don't know what violence against children represent and what exactly is a child in danger. We refer to the 2016 French child protection law, which doesn't speak of maltreatment, but only suggests a notion of risk, of danger, or danger. So that is quite a large definition, much wider than the maltreatment definition from the WHO. And mainly, we are asked to answer these four questions. Are we dealing with a situation compromising a child's health, his security, morality, or environmental conditions for his better development? So that's what we have to assess, and it's not always easy in a pediatric hospital setting. Obviously, the impact of the violence is different if it's past or persistent, if it's casual or chronic, intentional or not. And this definition is interesting because it's the law definition, but it's also a broader vision because it considers if a child's rights and fundamental needs are fulfilled by his caretaker. And so it implies an ecosystemic approach, and that is very interesting for prevention and decision making. So we used to use this pyramid we talked about yesterday, the Maslow's hierarchy of needs. In France, we use something called the Child's Fundamental Needs Chart, which is used by the Child Protection Services to analyze if a child has all his responses to his needs. And for French physicians, I like to think that my colleagues are mostly citizens, and so it's sometimes very important to give data and awful numbers just to shake them up and wake them up and say that this is not a social subject, but a pediatric subject. So in France, we have a few statistics saying that 75% of lethal violence occurs under age 5. 80% of sexual violence perpetrators are inside the family circle for children aged under 15, which is awful. 33% of parents are still unaware that customary violence is forbidden by law. And although we know the co-occurrence of violence, the cumulated health effects, the devastating and tremendous impact on individual and society, it still has to be a regular day-to-day reminder that there's a cumulative impact of poverty and maltreatment and a cumulative impact of chronic illness and maltreatment. So in France, there's unfortunately very, very little reliable data. Most studies often talk about what happens to the child once he's in welfare, so all his pathway, but not of how the professionals should use the guidelines. And interestingly, as in other countries, the first lockdown for COVID raised awareness to domestic violence because we have a hotline, it's a number called the 119, and there was a raise of 39% of calls dialed by the children themselves during the lockdown, so it was quite interesting. And the second factor that raised awareness was also a movement on Twitter, which was called #MeToo and #MeTooIncest, which raised awareness to sexual violence upon minors. So, in a hospital setting, what do we make of this? Unfortunately, even if there's a favorable mindset and people who are not underlooking the subject, we still have devastating findings, which is, first of all, that there's a very poor detection by healthcare workers. They only detect 2 to 5% of children who are potential victims. So there's an under-identification, under-reporting, and so hence an exposure to severity and increased severity as time goes by. And second of all, even when the child is protected by welfare and child protection, there still exists a risk, and he can be exposed to new violence or recurrences. And so, unfortunately, we have in France almost one out of 4 homeless young adults who are who were previously victims of violence during their childhood. So, what to do? Up till now, when a child was taken into care in a hospital as mine, it's a local hospital, so the children often come back regularly. And up till now, when a child was between 0 and 3 years, France has their children going to school at age 3. So, so the child is usually examined by a general practitioner or the PMI, which is a protective maternal and child public healthcare system. And most of the time, the practitioners didn't know where to send these victims or suspected victims of violence. And so we had to wait for the violence to be very visible and for the child to be addressed directly to child welfare or sometimes through the hospital, but it was often dealt with by social workers by themselves. And so we are wondering, are there any gaps? Isn't there something to do when the child is nonverbal, when the violence isn't visible yet? What to do? So we thought about that and thought that maybe we could improve quality of detection and management already through the same pathway, but also by detecting the siblings, which are often in consultation with the victim, and also using the means we have is that to do prevention from the maternity up till the verbal years of the child, and so to address them to the hospital much earlier and to find how we can be of help to the first primary healthcare practitioners and to improve what is already being done at the hospital. So there's a very strong suspicion that there are causes of delayed diagnosis, and these multiple causes are, first of all, lack of training. That is that's very obvious in medical fields. There is no forensic pediatric training. There is no training about how to interview a child who has been a victim, and there's no training about risk factors or really the outcomes, the negative outcomes of violence. Second of all, there are very poor abilities in management because doctors don't know about law, they don't know about procedures, they don't know about protection measures, and they don't know how to deal, for example, with the child who is himself an author, and they don't have time. Doctors are always running after time, and they find that all these measures are not in their field of action. And third of all, that's my topic, the implicit biases, which is that even if we have all the knowledge and all the training we need, if we don't want to see, we don't see. And that is the big problem, because there's a real gap between knowledge and pediatricians' practice. It has been said in many studies, but no one does anything about it. And so the implicit bias is a combination of personal mistakes, for example, in social cultural interpretations, which are totally mistaken. Also a combination of personal history or personal denial of the subject, a fear of disrupting a therapeutic alliance or a good relationship with a parent, more often, even more so if the child has a chronic disease and is always at the hospital. And there's also the fear of being wrong and the fear of lawsuits against oneself. So all this implies a great risk of diagnostic variability and the necessity of sharing the discussion and never staying for the doctor to never stay by himself. So the implicit biases are obvious every single day, because most of the time the child that comes to seek help, or the family that comes to seek help, looks like this one. They can be blonde with blue eyes, they can be rich, they can be loving and caring and kissing their child, but we still have to suspect something if we look at the medical examination and the forensics. So it's very troubling, and yet we need early detection, early intervention, and prevention. So how do we do it? We think that necessarily, as I said, we can't stay alone. We need to be several professionals, and if we have complementary points of view, the assessment will be better. We need to communicate. We need to take some time to deal with the whole process of care, and we need to feel competent about it and comfortable to discuss the matters. For example, a pediatrician who wouldn't like to discuss teenager sexuality will never be able to do prevention or manage correctly. The same thing with unaccompanied minors. Professionals who are not at ease with their migratory trip, by the law, their rights, cannot address him and reassure him. So these are obvious facts, but every day this is really what we see, and the phone calls we get are made by professionals who don't know how to deal with the subject. So multidisciplinary approach is not new. In the US, the child advocacy centers were invented in 1985. Up to date now there are 900. The Forensic Pediatric Society was born in 2009. In France, it was just created in 2017, so we're very late. We know that Iceland has created the Barnhuis models, which are now really developing in Europe. And these houses, these children's houses, are made for a quick response to victims or family of victims or witnesses of victims of violence, to assure prevention, protection, and rapid access to justice recognition. And the staff is made of physicians, mental health therapists, child protection personnel, social workers, and justice. So there's the child advocate and the prosecutors and police. That's how these houses function. And in Scandinavia, there's also a child's judge, because the procedures for welfare and criminal justice are conducted by the Barnhuis themselves. So that is not yet the case in France. There are a few houses on this model that are being invented in France, but they're still few. And we would like to know if it's a model that could be generalized. So is the ministry ready? I think the politicians are starting to get ready, because they, after COVID also, they started to structure a medical pathway for children's mental health. And in this process, it was obvious that violence had to be a subject and a topic. And so after the primary health care professionals, we come in second position at a departmental level. So there is a demand since end of 2021 for one unit of this type in every department, and also an expertise reference team for several departments. So that is what is demanded by the IRS, the Regional Health Agency. And the Ministry of Justice is also implied, because there is a will to address minorities, the social deprivation minors. So there's also a demand so that in every pediatric hospital there be a place for free access to healthcare, even specialized consultations. And also a last topic about unaccompanied minors. So there's a EUPROM, European Association, which works between France, Spain, Italy, and Sweden to address what's at stake and how to manage unaccompanied minors' violence. So things can evolve. Humbly in our hospital, so I was the first unit of this type that existed in Paris. We have a very big activity, a maternity also, and a population which is extremely diverse in cultural and economic backgrounds, and we receive more than 100 unaccompanied minors a year, and so we are very, very conscious of the impact of social deprivation on risk of violence. In our hospital, so I was internized UAPED, so Unité d'accueil pédiatrique d'enfants en danger, which means Child Prevention Protection Unit, and I'm also expert for toute l'Île-de-France, for several departments. Our team is a very little team. We're only 3. There's a full-time physician, your servant, for clinical advice, forensics, child protection, and parental guidance. That's my training, and I supervise the public consultation for the unaccompanied undocumented minors. There's a full-time pediatric nurse, Monica, which is my colleague, who spends a lot of time assessing mother-child relationships, parenting support, and she also has a great network of postnatal access to healthcare for very socially deprived, so she's a tremendous help, and a full-time psychologist, which is trained in psychotrauma. We work with the social workers of the hospital and also the social worker specially dedicated to the precarious. We have a translating service and a social cultural mediator who can advise us on how to apprehend, is it maltreatment or is it a cultural interpretation? It's very important to have that. And we are building a forensic interview room, which is in progress because that was a demand of the ministry. There was a big debate because many doctors didn't find that it was ideal to have justice invade the hospital, but in a few situations for very, very fragile minors who cannot be transported, who are extremely anguished, it can be very interesting to have them stay in their room and have the police come to them instead of them having to go to several police departments and to forensic departments. So that's quite interesting, and the police would come and interview them. We would record and keep the proof for the justice record. So that's our team. This is what my desk looks like because because of this big activity, I don't have time to be everywhere. But when I arrived, I really didn't think there would be that much activity. I didn't even know if I would be back home unemployed in 6 months or so. And in fact, on day 2, 10 phone calls. Day 3, 15 phone calls. And now we're dealing with 45 new situations of danger. So it's not a nice number. 45 new situations every month, so which is huge. And we have above 400 children which are regularly in our follow-up register. So it's interesting to see that even if the social workers do that job, they call us, doctors call us, psychologists call us, judges call us, midwives, every place, even surgeons, which is rare, and they often call us for psychological violence. When the physical violence is obvious, they know what to do, but they don't know what to do when there's neglect, when there's parenting, negative parenting, domestic violence. They really don't know what to do. So that's what we try to do, and to help them make decisions and think about the situation through the lens of the trauma-informed care because of our training, because also we know how to assess correctly a situation. We know how not to overemphasize the preoccupations, and we know how not to wait too long. We try to help them and assist them in reporting. We do in France. We have to report by writing procedures and sending them to the child welfare services. So we try to help them report the correct way, and especially the novelty is that we try to really implement parenting support and healthcare access for everyone I think I do some training every single day, sustainable training to all staff, medical or not, to try to standardize the methods, collect data, and to go towards research with all this. So this is just to show that I'm never alone, that we're very, very communicative. We're all day long sharing the situations. I have a direct phone call to the prosecutor, which is really a help, a direct phone call to the head of the police department for minors, which is really also great. So it can help to be on good terms with them. And so that means that the child which will be stepping into a very long and painful procedure will be accompanied by us from the start, even before the violence occurs, when the risk factors are there, until the end of the procedure. So it can be long. It's very tiring for a mind because we never know what the outcome will be. But it's a great job, and I love my job. And so this is the pathway of the child from the arrival in emergency until the end. That's just a reminder that we try to really use the recommended methods for the Forensic Pediatric Society. We use the protocol, the niche protocol for the interviews. We do exactly the right biological and radiological exams, and we try, especially at the end of the pathway, to especially look out for their trauma care. The parental guidance will continue, but especially the follow-up in pediatrics is very, very important for us. We focus on partnership. We really, really target partnership because we cannot establish bridges between the inner and the outer hospital in the interest of these children if we don't have good relationships with all the partners. So in maternity, we will often work with the women's rights associations. We will often work with the police, obviously, and the courts and judges. But for all the poverty situations, we have many associations who help us. We have also the education which orients many, many children. And so partnership is the key. Is the key to finding a solution. Protocols are also the key to help the colleagues. For each situation, we have tried to think of protocols and tools and resources which can help them on a day-to-day basis. What's interesting is for the shaken baby syndrome, we can do autopsies and really try to reach out towards the siblings. Sexual violence is huge at the moment. We have regular, everyday, we have many phone calls for that, so we try to train people to not having the right, to not over-traumatizing the patients. School bullying is an issue also in mental health, so we try to work with the school hand in hand. And for neglect, domestic violence, intimate partner violence, and structural violence, we can do nothing else but be there. Be there, always take care of the child, be vigilant, take care of the siblings, do the follow-up, and take care of the parents. I'll try to accelerate. Prevention throughout it all is always there, and research is extremely important. I just want to say that these are a few examples of what we put into place. For example, I can teach the students and the young doctors how to recognize a maltreatment bruise. We can teach them how to do the correct exams. We can teach them how to screen correctly. But real life detecting can be very tricky. For example, these two examples are quite easy and obvious. Hematoma on a genital area is not normal for a tiny toddler. The second photo, you can really see the shape of the instrument that was used to burn the child. But the third one is a trick because it's not maltreatment. It's a maternity, I don't know how to, the spatule. The instrument used at the delivery. So it's a trick. Another trick is most of these children who are maltreated are usually not crying. They're usually smiling and laughing for those who walk, running around and jumping around. And so it's good to remind that they don't obviously automatically feel pain and that you can still screen them for violence even if they don't express pain. Structural violence, we try to teach about psychotrauma risk during migration. We try to teach about attachment, what is a correct form of attachment. The Canadians have a great definition. Every child needs at least one person in his home who would give up everything to take care of him, who would constantly be there. It's a very simple but very accurate definition. One child just needs one person who will always be there for him, whichever his needs. And it might be the person on the right and not the person on the left, right? So it's especially difficult when the children have handicap or chronic illnesses, because I'd like to tell you very quickly the story of Kevin, who was 11, who consults regularly for chronic pain and handshaking. He's never been diagnosed, and the social worker believes his mother is amazing because she's always at the hospital, she's always calling, she's always worried. One time she even said that she had seen 14 specialists for her son in the past 18 months. No diagnosis, they all said he was fine, but she's very upset. She goes to the emergency department and she says, he's so much in pain, I had to give him morphine and he's in a wheelchair. I want some anticoagulants and I need money because he's handicapped, I need help. The social worker establishes a link with the school social worker. And she had made, I don't know how to say cagnotte in English, she had gathered a huge sum of money online on Facebook by filming her son and saying he was doomed with an incurable illness, and so she had to buy special machines to help heal him. Kevin felt oddly better. He loved to play football when we asked him, but he had trouble sleeping, and he ate much less. When he saw the doctor and psychologist, he seemed very sad, confused, and the mother very angry because we kept saying that he had to go back to school. He was in homeschooling for a year and a half. And at that time, I shuddered because I asked him, what job would you like to have when you grow up? And he just answered, I won't have time, I'll be dead by then. So that's exactly, maybe some of you have the diagnosis. Yep, everyone has it, Munchausen by proxy. It was terrible because he was really convinced he was going to die very soon. So we did the reporting without informing the mother because he would be at risk, and she found out that we had done the reporting, and the next week she sent us a photo of his hands burnt, second-degree burnt, because she had really plunged them in caustic fluids, just to prove us that we were wrong. So it was dreadful. And a year later, he was in depression, and he was just trying to get out of it. But that's the difficulties of this situation, who had been followed up for a year and a half, and the reporting was done with 7 doctors who wrote down. Everyone had gathered the preoccupation. So that's the reality. It's not as easy as in theory. Sexual violence is the same. We have Dahlia, 16 years old, who comes regularly for burns, bruises. She's always asking for a pregnancy test, 16 years old. Once she arrives drunk, another drugged, and we find out that she's been exploited in a sexual prostitution network. And when the police interviewed her, she was laughing away, saying she was fine, that she needed no help at all, and that we had invented everything. So we had to do 4 reportings, and 1 year later, she was at last in security and in foster care. So we give tools. We try to guide and try to say that if a child says he has been molested or victim of sexual violence, try not to say, oh my God. Try to avoid facial expressions which will dissuade him from keeping in touch with you and talking to you. And so in conclusion, I would just finish by saying that to me, it's obvious that it's a multidisciplinary approach that we need. It has to be a minimum standard. And we need teams who are correctly trained, neutral and professional, addressing all types of violence. I would like, in a few child advocacy centers, they target only one type of violence. I don't have time for that. I wish we could, but it's too ambitious for the moment. But we will try to narrow it down to a few topics. But the main message is that these units can be safe places for children, and the real aim is to avoid re-traumatization by the whole justice pathway they will go through, and to be there also for the maltreating parents, because even parents who are offending need sympathy and empathy, because we need to help them also find their own way, and everything has to be done in the child's best interest as a primary consideration. That's the end, just to show you that these units are developing in Paris and in France, and there are so many challenges for research because nothing has been done, that these are really the following challenges for the years to come. But to implement, first of all, to implement all our work would be great, to see if the prevention and intervention programs are efficient. That would be fantastic. But and secondly, to join national and international research networks like this one is a great. It would be fantastic. Thank you very much.
Thank you so much, Tania. You're remarkably upbeat, given the nature of this work. Yeah, I spent years doing this, and it is quite difficult to maintain your enthusiasm and
We obtained supervision for personal psychological supervision for us, because I felt that all our teams are tired. So
yes, yeah. Well, you'll need it. The supervision, but the assistance, I think, with this. Yeah. Questions? Pierre.
Per Andersson, White from Sweden, and in our law we have there's a law that said that we have to contact social services if we suspect any sort of we have a worry for the child's safety is how they define it. Is it the same in France? Are you obliged by the law to report?
Yeah, we are obliged to either report ourselves or make sure we transmit the information to someone who will. So, for example, if we feel confident to do the proceedings ourselves, the procedures ourselves, we do them ourselves. But if, for example, I'm a general practitioner and I'm afraid to do it, or I don't feel confident, I'm obliged to transmit it to a social worker or to a unit like ours at the hospital. So there is this, obviously the law really obliges the healthcare workers to not stay and sit around and do nothing. They need to transmit the information.
It's a good support.
Yes. That's a good support for training them, because most of them are skeptical. Not most, that's wrong. Some of them are skeptical and reluctant, and so we need to we need to argument with the law to train them. Yeah, and change the mentalities, yeah.
Sue, paediatrician from Sydney, and I've spent 10 years doing child protection on call and working in a forensic unit. And I'm just very aware that there are many great examples worldwide of forensic training, simulation training, scan protocols, so that you don't, because there's only one of you and I'm like, she's at risk of burnout, no matter how jolly she is. In terms of, it would be worthwhile, and you probably already have done this, looking at, I'm very happy to share stuff from Australia or the EU in terms of what people have already done in terms of standardising training and scan protocols, and most importantly referral pathways, because you cannot be the person who gets all the cases coming your way. There is just, it's totally unmanageable.
Yeah, of course. Yeah. In terms of training, we are planning to do a simulation training. We have already prepared an e-learning training for all childcare givers and primary healthcare and education, and also for parents, so we're aiming that. It's a little bit difficult to transpose from one country to another, but obviously, that's something we need to develop and base ourselves on what has been done. Yeah, thank you for...
Okay, thank you very much, Tania.